النهارده إن شاء الله هنتكلم عن الأبدومينال hernias. By definition, an abdominal hernia is a protrusion of a viscous or part of a viscous within a peritoneal sac through a defect in the abdominal wall. طبعا احنا هنا في تحفظ على within a peritoneal sac لأن في عندي some hernias without a sac. هنتعرض لها إن شاء الله بالتفصيل في خلال كلامنا اللي جاي. Etiology: there are congenital causes, predisposing factors. ما هي إلا predisposing factors which are either a congenitally preformed sac such as an infiltrated portion of the processus vaginalis or a congenital defect in the parietes such as apertures in the linea semilunaris, diaphragm, pelvic floor, and also very rare there is a defect in the congenital tendon leading to a congenital type of direct hernia called oglivi hernia. Nowadays فهمنا للhernias ان for a hernia to happen there should be a disturbance on metabolism. احنا عارفين ان عملية البروتين ميتابوليزم او الانابوليزم المفروض ان هي rely or depending على some sort of balance between the proteolytic enzymes and the anti-proteolytic enzymes. المحصلة في النهاية هي ده هو اللي بيحكم عملية الوير and tear mechanism. إحلال وتجديد for proteins للستراكشرز اللي هي بتعمل لي defense against the occurrence of hernia. لو البروتيوليتيك انزيمز كان ليها الغلبة على الانتي بروتيوليتيك انزيمز يبقى عملية البروتين ميتابوليزم ماشية في اتجاه الكاتابوليزم. لو الانتي بروتيوليتيك انزيمز هي اللي ليها الغلبة يبقى اللي بيحصل في المحصلة في النهاية ان عملية الانابوليزم هي اللي ليها الغلبة على الكاتابوليزم. So for a hernia to happen المفروض ان بيحصل فيه some sort of imbalance between the proteolytic enzymes and the anti-proteolytic enzymes بيكون محصلتها في النهاية ان بيحصل فيه عملية كاتابوليزم more than the anabolism. في النهاية ده هو بيؤدي للmuscle weakness والoccurrence of hernia depending على presence of a congenitally preformed sac او presence of a congenital defect بيحدد ده هو التايب of hernia. ده هو recent understanding of the etiology of hernia. تاني factors classically ممكن نقول انها مسؤولة عن occurrence of hernia are the acquired causes. دي بنسميها ما هي الا precipitating factors and these include the raised intra-abdominal pressure whether due to obesity, heavy work, chronic cough, or straining at micturition or defecation, and weakness of the abdominal wall as a result of pregnancy, obesity, operative intervention, old age, or debility from other cause. Surgical anatomy. A hernia is composed of three parts: sac, contents, and coverings. Sac. The sac is a protrusion of peritoneum which consists of two parts, the neck and fundus. The neck is usually narrow and well defined, but sometimes it is wide and ill defined, as in direct inguinal hernia and in incisional hernia. وفي الحالات دهية بيبقى الانcidence of complication is very low. The fundus is at first small and thin, but as the hernia increases in size, it enlarges partly by stretching and partly by drawing down of adjacent peritoneum, which may pull out the enclosed viscous as a sliding hernia. Contents. Any abdominal viscous except the pancreas may be found in a hernial sac, but the commonest contents are omentum, and in such cases the hernia is known as epiglossal or emonticele. The hernia feels dewy in consistency and dull on percussion and reduces without a gargle, and its reduction of course is easy at the start, difficult at the end. or ان الكونتنت دي تكون intestine ولحظتها هنسميها انتيروسيل. هيكون الفايندنجز اللي فيها، الفايندنجز اللي موجودة فيها ان هي بتبقى resonant on percussion, soft in consistency, difficult reduction at the start, and easy at the end. Sometimes the intestinal protrusion consists of a portion of the circumference of the bowel in Richter's hernia, a Meckel's diverticulum which is called Littré hernia, or a double loop with an intermediate loop in between which is called the Miedel's hernia. This intermediate loop of course lies inside the abdomen. ثالث مثال من أمثلة الcontents is urinary bladder. A portion of the urinary bladder may protrude into the inguinal or a femoral hernia. Depending on the relation of the bladder to the peritoneum, three varieties of such hernia are recognized. أولهم intraperitoneal type, in which the urinary bladder herniates into a complete sac. Extraperitoneal type, the bladder protrudes through the hernial apertures without any sac. And the last type is the paraperitoneal, the bladder protrudes along the inner side of the sac, lying outside it as in a sliding hernia. رابع مثال من أمثلة الكونتنت is the ovary and fallopian tube. The hernia هيميزها إن هي in such cases usually irreducible, and pressure on the contents causes sickening pain. The coverings for each hernia, for each type of hernia, الcoverings تبقى derived from the various layer of the abdominal wall through which the hernia passes, and as it enlarges they become stretched and matted together. Clinical features for any hernia. The patient usually presents with a rounded or a piriform swelling at one of the hernial sites. So cardinal إن هذا السويلنج يبقى موجود at one of the hernial sites. Characteristically, the swelling is intermittent, enlarging when the patient stands, coughs or strains, and diminishing in size on lying down. وده اللي بنسميه history of intermittency. On examination هيكون موجود فيه expansile impulse on coughing, which means that the swelling expands in all directions when the patient coughs. تاني حاجة reducibility. The swelling can be reduced into the abdomen when manipulated. المقصود بكلمة manipulation إن بيحصل بعمل reduction in a certain direction, and a characteristic gargle may be felt during reduction. Aperture or the defect. The hernial orifice may be palpable, and when obliterated with the thumb after reduction, the descent of the hernia is prevented. Consistency of the swelling. Uncomplicated hernia feels soft in consistency, and if sometimes alone is present, لو الأومنتم ده هو موجود منفردا دون الانتستين with it هيبقى الكونسستنسي بتاعها دوي inconsistency. في المقابل لما تبقى الفيلينج of the consistency is tense، ده بيبقى موجود في حالات strangulated hernia. Percussion. A tympanic note is usually obtained on percussion when it contains bowel. Transillumination. The swelling is opaque on transillumination. التحفظ إن هو ممكن يبقى translucent in congenital hernia in children up to 2 years. Treatment is either by truss or operation, but it is always important to correct any predisposing cause before local treatment is carried out. Truss treatment is obsolete now. It is merely a palliative measure, which is recommended only when the patient can't withstand operation or when the hernia is very liable to recurrence. بالتأكيد حاليا anesthesia can be tailored for every patient. دي واحدة. والrecent methods for repair دايما بيبقى الريكارنس فيها very low. so عشان كده احنا بنقول ان هذا التريتمنت is obsolete now. زي ما تعودنا في الجراحة ان ال policies for surgical treatment are either one of two: wait and see policy، ودي كانت ممثلة في التراس، and open and see policy، ودي متمثلة في الoperative repair. Three types of operations can be employed. أولهم herniatomy، وده هو عبارة عن complete excision of the sac without any form of repair. It is suitable only when the hernial aperture is very small and the anatomical structures around are normal, as in infants and children. Tiny method for operative treatment is herniorrhaphy, which consists of complete excision of the sac and the repair of the defect by suturing. It is a standard procedure for most cases. Third method of treatment is hernioplasty, in which some grafting material is used to close the defect, and it is indicated for large hernias in elderly people and for recurrent hernias. Complications of hernia. The most important complications are irreducibility, which means that the contents can't be returned to the abdomen, but the expansile impulse is still present and there is no pain or other serious symptoms to differentiate it from the most grave complications, strangulation. The condition may be due to adhesions within the sac, overgrowth of the omentum, sliding hernia, or contraction of the neck of the sac. Treatment: operation is always advisable since no truss can be fitted and the risks of strangulation are great. The second complication is obstruction or incarceration. An obstructed hernia is an irreducible hernia containing gut, the lumen of which is occluded by fecal masses. The patient complains of colicky abdominal pain with vomiting, distension, and constipation. These are the four cardinal manifestations of obstruction. The hernia becomes distended and irreducible, but remains soft. A dewy fecal mass is often palpable within the sac. Treated by enemata and gentle taxes, but owing to the risk of strangulation, operation should be performed as soon as possible. The third complication is inflammation, which may be due to trauma by unsuccessful attempts at taxes or the pressure of an ill-fitting truss, or inflammation of the contents, such as the appendix or ovary, or strangulation of an epiploceal. البيكتشر بتاعتها: the hernia becomes painful, swollen, and irreducible, but unlike strangulation, the consistency remains soft. Later on, the overlying skin becomes congested and hot, and fever and other signs of toxemia appear. Treatment is by antibiotics and hot fomentation, but if no rapid response is obtained, operation should be performed. The first complication is strangulation. This is the most serious complication of a hernia because the contents are so constricted that their blood supply is seriously impaired and gangrene follows rapidly. Obstruction of the lumen is not an essential feature in strangulation as it doesn't occur in cases of epiploceal Richter's hernia and the Trey hernia. In strangulated Middle's hernia, the intermediate lobe within the abdomen may become gangrenous, whereas the second herniated lobes escape, which is known as retrograde strangulation. Incidence: strangulated hernia accounts for about 50% of all cases of acute intestinal obstruction. Although strangulation occurs in about 50% of inguinal, 20% of umbilical, and 30% of femoral hernias, yet owing to its much greater frequency, inguinal hernia accounts for over 50% of all strangulated hernias. Etiology: the constricting agent may be a rigid structure outside the sac, like Gimbernatt's ligament in case of femoral hernia, and the crura of the external ring in inguinal hernia, the thickened and contracted neck of the sac, or bands and adhesions within the sac itself. Predisposing causes of strangulation are extrusion of additional contents as a result of some violent strain. External trauma such as repeated attempts at taxes and local complications of the hernia like irreducibility, obstruction, and inflammation. Clinical feature: the hernia suddenly becomes very painful, tense, and irreducible, and signs of intestinal obstruction soon appear with shock, vomiting, distension, and constipation. There is loss of expansile impulse on coughing. When gangrene occurs, the overlying skin becomes congested and edematous. And if the patient survives, sloughing of the hernia occurs with the formation of fecal fistula. Treatment is usually by urgent operation and rarely by taxes. What's meant by taxes? It is the manipulation by means of which a strangulated hernia is reduced. Indications بتاعته: permissible only within the first 6 hours after the onset of complication, and only in previously reducible hernias. It is successful more in children and infants. Technique: the patient should lie on his back with thighs flexed to relax the abdominal muscles. Even analgesia is given to relax the muscles. With one hand manipulating the neck, the hernia is gently squeezed with the other hand in the direction of the hernial aperture. So the part recently protruded is returned first. Complications of taxis. It is called with many complications, وبالذات إذا خالفنا solid indications for taxis. So it is better avoided as it is attended with many risks, which include rupture of the sac with reduction of the contents in extraperitoneal tissue, which is known as interstitial reduction. Rupture of the bowel at the neck of the sac. Reduction of a gangrenous bowel, which is a catastrophe, leading to peritonitis. Reduction of the sac with the contents into the abdomen or between the abdominal muscles, which is known as reduction in Massey. Reduction of the contents from the main sac into a secondary saccule between the layers of the abdominal wall, known as reduction in bisac. Volvulus of the reduced bowel, and lastly, shock due to pain. Operation should be undertaken as soon as possible, since gangrene is liable to occur within a few hours. The patient is rapidly prepared by suction, intravenous fluids, and general or spinal anesthesia or local anesthesia may be employed. Technique: the fundus of the sac should be exposed and opened firstly before the constriction is relieved, so the toxic fluid within the sac doesn't contaminate the peritoneal cavity. The left index finger is then inserted into the neck of the sac to feel the constriction, which is relieved by cutting of the coverings layer by layer down to the neck. The contents are then drawn well out of the wound so that the constriction grooves can be examined and the possibility of retrograde strangulation in case of Middle's hernia can be excluded. The contents are then dealt with as follows. Omentum is excised whether viable or not. Viable bowel is returned to the peritoneal cavity. Gangrenous small intestine is resected. Gangrenous colon is exteriorized, and doubtful bowel is wrapped in warm saline bags for 5 minutes, during which the lungs are flushed with pure oxygen. And if no change of color and appearance is observed, it is treated as non-viable bowel. Finally, the sac is excised, and if the general condition permits, herniorrhaphy may be carried out, not hernioplasty. The wound should always be drained. The fifth complication is rupture of the hernia, which may follow trauma. Sixth one is torsion of omentum during taxis, which is rare. Seventh one is hydrocele of hernial sac, which may follow occlusion of the neck by omentum or adhesion. It occurs most often in the inguinal region as a mobile cystic swelling in the cord, which retains its mobility on traction upon the testis, unlike encysted hydrocele of the cord. The eighth complication is recurrence. هنتكلم دلوقتي عن types of abdominal hernias. It can be classified into external hernia, internal hernia, and retroperitoneal hernias. The classification into external and internal hernias depending on its location outside or inside the abdominal wall. External hernia can be classified into groin hernias, which includes inguinal hernia, femoral hernia, and furtherly, inguinal hernia can be classified into direct inguinal hernia and indirect inguinal hernia, and both hernias together, which is called as pantaloon or saddleback hernia. Second variety is ventral hernias, which includes umbilical hernia with its congenital, infantile, and adult type variety or para-umbilical hernia. Second type of ventral hernias is epigastric hernia and fatty hernia of linea alba. Third type is inguinal hernia, which follows previous surgery. And lastly, Spiginian hernia, which is hernia of the linea seminaris. Lastly, traumatic hernia, which is due to trauma like falling from a height. Internal hernias, which are hernia in recesses, hiatal hernia, which is subdivided into sliding, paraesophageal or rolling type, and mixed type. ثالث نوع من الانترنال hernias are diaphragmatic hernia through the cupola and not the hiata, the esophageal hiatus. Third type of abdominal hernias are retroperitoneal hernias, which includes lumbar hernia, gluteal hernia, pelvic hernia, which is obturator hernia, sciatic hernia, and perineal hernias. هنتكلم دلوقتي على الانجونال hernia. المقصود بالانجونال hernia is that hernias which traverse the inguinal canal to emerge at the external abdominal ring. Depending on the exact site of the aperture, two varieties are recognized, the oblique and the direct variety. Surgical anatomy of the inguinal canal. It is oblique, directed downward, forward, and medially. It has the following boundaries. Anteriorly, external oblique aponeurosis all through the wall. The lateral fibers of internal oblique at the lateral half. Posteriorly, transversalis fascia, conjoint tendon at the medial half, and the reflected part of inguinal ligament at the medial force. Superiorly, the arched fibers of internal oblique muscle. Inferiorly, base of the inguinal ligament. Roof is formed by internal oblique, floor by the inguinal ligament and the pectineal ligament. The inguinal rings are the superficial inguinal ring, which is opening at the external oblique aponeurosis and lies just above the pubic tubercle and transmits the spermatic cord. The deep inguinal ring is opening in the fascia transversalis, lies half an inch above the mid-inguinal point, which is lateral to the inferior epigastric artery. Fascia transversalis is that part of endo-abdominal fascia enclosing the abdominal cavity, deriving its name from the overlying transversus abdominis muscle. This fascia is continuous with the following: above with the diaphragmatic fascia, below with the pelvic fascia and the anterofemoral sheath, posteriorly to fascia iliaca and renal fascia. Parts of the fascia transversalis: Henel's ligament, which is thickening of the extreme medial portion of fascia transversalis in conjunction with the pubic insertion of rectus abdominis muscle. Haselbach's ligament, which lies just medial to internal ring. It strengthens the medial margin of the ring. Rectus fascia is the fascia transversalis, divides medially to invest the rectus abdominis muscle. Iliopubic tract, which is attached laterally to the anterior superior iliac spine and medially to the pubis. The spermatic cord coverings are internal spermatic fascia derived from fascia transversalis at the deep inguinal ring, cremasteric muscle and fascia from internal oblique muscle, and external spermatic fascia derived from the external oblique aponeurosis at the superficial inguinal ring. Contents: vas deferens, arteries, testicular artery or internal spermatic artery, cremasteric artery, external spermatic, and artery to the vas. Veins, bambiniform plexus of veins, which form the testicular vein that end in the left renal vein on the left side and in the inferior vena cava on the right side. Lymphatics of the testis. Nerves, the sympathetic fibers from the hypogastric plexus, genital branch of the genitofemoral nerve. Normal protective mechanisms against inguinal herniation. أولهم shutter mechanism, which is a complex one. It occurs on straining the arched fibers of the internal oblique muscle and conjoined tendon descends downward while the inguinal ligament ascends upward to obliterate the gap in between. Plugging mechanism. On straining, the cremasteric muscle contracts upward, taking with it the spermatic cord which plugs the deep inguinal ring. Sliding mechanism. On straining, the deep inguinal ring becomes slit-like because it is pushed up and laterally by the action of transversalis fascia. The valvular mechanism. On straining, the anterior wall approximates to the posterior wall, thus occluding the canal. Lastly, the obliquity of the inguinal canal. It is 1.5 inch in length, extending from the deep inguinal ring to the superficial inguinal ring, and contains spermatic cord or round ligament of the uterus, ilioinguinal nerve, which overlies the cord in the canal, and lymphatics. في خمسينات القرن الماضي كان في الانترودكشن of the concept of the myopectineal orifice of Frosched to describe the area of weakness of the groin ان من خلالها بيفسر occurrence of all types of groin herniation ودي كان بعد كده هو الأساس في ترسيخ الانترودكشن of the basis of Liechtenstein repair. It is an anatomical hole located between the false pelvis and ipsilateral lower extremity. This is a weak area in the groin where the posterior layer is not protected by overlying muscle. The myopectineal orifice is quadrangular in shape or lozenge shape and is divided into a superior and inferior level by the inguinal ligament. Its role is to allow the passage of spermatic cord structures superiorly and the femoral vessels inferiorly. The boundaries of the myopectineal orifices are the arching fiber of the internal oblique superiorly, the rectus abdominis muscle medially, the anterior border of the iliac bone inferiorly, and iliopsoas and iliopectineal arch laterally. This anatomic hole can be further divided into 3 anatomic triangles, the medial, lateral, and femoral, which are the potential sites for groin herniation. The diagram describing the myopectineal orifice divided into superior level and inferior level by the inguinal ligament. Furtherly, the superior triangle is divided into medial and lateral, and the inferior level is the femoral triangle. The medial triangle is a space encircled by the arching fibers of the internal oblique superiorly, the rectus abdominis muscle medially, the inguinal ligament inferiorly, and deep epigastric vessels laterally. This medial triangle within the myopectineal orifice is the site of direct herniation within the groin. The next anatomical triangle within the myopectineal orifice is the lateral triangle, emphasized by Gilbert. This anatomic site can be placed at risk for future herniation when herniorrhaphy procedures fail to address this region and to concentrate on supporting the medial myopectineal orifice. The triangle is defined by boundaries بتاعته: the deep epigastric vessels medially, the inguinal ligament inferiorly, and a line drawn from the lateral inguinal ligament to the intersection of the deep epigastric vessels with the arching fibers of internal oblique muscle. The final triangle within the myopectineal orifice is the femoral triangle, located in the inferior aspect of the myopectineal orifice. This area is bordered by Cooper's ligament inferiorly, the inguinal ligament and iliopubic tract superiorly, and iliopsoas muscle laterally. So, all groin hernias begin as a weak area in the myopectineal orifice. The transversalis fascia layer deteriorates and allows peritoneal protrusions through it. Depending on the length of the intersection of the transversus abdominis on the Cooper's ligament, the presence of a patent processus vaginalis, and the size of the femoral ring, the hernia can be direct, indirect, femoral, or any combination of the three. Groin hernia can be corrected by either repairing all or part of this myopectineal orifice, or by substituting a prosthesis for the deteriorated fascia transversalis. نتكلم دلوقتي على الأوبليك inguinal hernia regarding the etiology of the hernia. Classically, التيتشنج كان إن عبارة عن most oblique inguinal hernias in children and young adults بتحصل على background of preformed sac which represent a partially or completely patent process vaginalis, and in old age most cases are due to the formation of a Balshan sac as a result of muscular weakness and raised intra-abdominal pressure. أفكركم إن هي كانت الكلام إن هي بتحصل على metabolic background. هذا الميتابوليك background مسؤول عن the deterioration of fascia transversalis and its yielding in front of the raised intra-abdominal pressure. ونربط الكلام ده مع الكلام اللي احنا عرفناه في خلال شرحنا عن المايوبكتينيال اوريفيس، ان هي depending على اذا كان موجود فيها congenital preformed sac بيحصل herniation as an oblique inguinal hernia. اما اذا كان في narrow insertion of the conjoined tendon to the pubis بيحصل فيها direct hernia، او اذا كان فيها wide femoral ring بيحصل femoral herniation. اذا كان موجود combination هيحصل فيه combination of hernias. Anatomical types of oblique hernia. The common varieties are funicular. The tunica vaginalis is normal, اللي هي surrounding testicle, and the sac represents the proximal portion of the process vaginalis only. Infantile type. The tunica vaginalis extends upwards towards the internal ring so that the sac passes down behind it. So at operation the tunica is liable to be opened. أكن أنا عندي two sacs behind each other. The tunica is liable to be opened in mistake for the true sac, which will be found behind it. The congenital variety, the whole process vaginalis is patent, so that the sac is continuous with the tunica vaginalis and the testis lies among the contents of the hernia. Though called congenital, it may not be apparent until adolescence or adult life. The next type is the interstitial type. This type occurs most often in association with undescended or mal-descended testis, where the sac passes between the layers of the abdominal cavity of the abdominal wall instead of descending into the scrotum. It may pass between peritoneum and fascia transversalis, which is known as pro-peritoneal type, between internal and external oblique intraparietal type, or between the skin and the external oblique proparietal type. Sometimes the hernia starts with an ordinary sac, which becomes obstructed at the external ring, so that extends between the muscles as bilocular sac. Next type is the saddleback type. There are two sacs, direct and indirect sacs, separated by the deep epigastric artery, hence the term pantaloon hernia. At operation, the direct sac is drawn lateral to the deep epigastric vessels by traction on the oblique sac, so that the two sacs are converted into one. The next type is sliding or hernia englacade. This variety is especially common in elderly patients with long-standing large hernias. The sac enlarges by drawing on the posterior parietal peritoneum covering the cecum or pelvic colon, which passes through the inguinal canal outside the sac. At operation, it is impossible to separate the sac from the bowel, which should be elevated with a fringe of the sac, making a U-shaped incision around the bowel and closing it longitudinally. الدياجرام الآتي بيوضح هنعمل ايه at operation. This is the cecum موجودة في الوول بتاع الساك. بعمل U-shaped incision around the cecum وادخل السيكم intraperitoneal. هذا اليو شيبد انسيجن هبتدي اقفله longitudinal وبعد كده بعمل herniatomy اكمل في السيم لاينز اوف تريتمنت عادي بعد ما دخلت هذا الاورجن intraperitoneal. Clinical features. Incidence: oblique inguinal hernia accounts for about 70% of all hernias. It is commonest in infants and children and young adults, and in about 30% of cases both sides are affected. Males are affected more, or at least 20 times more often than females, and the hernia is slightly commoner on the right side, probably due to the later descent of the right testis. Symptoms: the patient complains of pain and intermittent swelling at the groin, which appears during standing, coughing, straining, or exercise, and disappears on lying down. Signs: the swelling may be limited to the groin, poponocele, or may reach the scrotum, scrotal hernia, or complete. The following signs can be elicited. أول sign can be elicited is expansile impulse on coughing. 2. Reducibility, which is an upward, then outward, and finally backward direction by gentle squeezing over the fundus. The line of descent is on the opposite side on standing or coughing after reduction. Internal ring test. Pressure with the thumb over the internal ring after reduction prevents descent of the hernia and abolishes the expansile impulse on coughing, which is interpreted as a positive internal ring test. External ring test. Normally, the external ring doesn't admit the tip of the little finger. In inguinal hernias, it becomes wide enough to admit the tip of the finger by invaginating the lateral aspect of the scrotal skin. If the patient with an oblique hernia is asked to cough while his finger is inside the canal, the expansile impulse will be felt at the tip of the finger, whereas in a direct hernia it will be felt at the back of the finger. Also, it assesses the musculature of the anterior abdominal wall, if it is good or weak. Consistency. An enterocele is soft and resonant on percussion, but an epiploccele feels dewy and dull on percussion. Relations. The pubic spine lies on the inner side of the swelling, with pubert ligament below and laterally, and the vas below and medially. Except in congenital variety, the testes can be felt distinctly at the lower and back part of the swelling. Transelimination. The swelling is always opaque in transelimination, but in infants and children it may be semi-translucent. Treatment. Truss. In infant, truss treatment often succeeds in curing the hernia by obliterating the sac, but it is useless after the age of 2 years. A horseshoe-shaped truss of solid rubber with pads over the inguinal canal should be applied continuously day and night for 1 year. In adults, truss serves as a palliative measure when operation is contraindicated because of advanced cardiac, pulmonary, or systemic disease. Operation in the form of herniotomy, suitable only in children and young adults, provided the aperture is small and the abdominal musculature are strong. Technique. An incision is made 1 finger breadth above and parallel to the medial 2/3 of the inguinal ligament. The external ring is exposed and the internal oblique aponeurosis is incised in the same line of the fibers to open the inguinal canal from the external ring to the level of the internal ring. The cord is then hooked on the finger and held up in a ring forceps or over a strip of gauze. The coverings are incised longitudinally, taking care not to injure the ilioinguinal nerve. The sac is usually anterior to the structures of the cord and can be readily identified by its barely white color. The coverings are separated by blunt dissection until the fundus of the sac is seen. The edges of the fundus is caught by artery forceps, and separation of the sac is continued until the neck is exposed, as indicated by the adherent condensation of fat and the presence of the inferior epigastric vessels at its medial side. The sac now is opened at the fundus, and any adherent contents are separated and returned back to the abdomen. The sac is next twisted to narrow the neck, which is transfixed and ligated with chromatized catgut as high as possible. The sac is then excised about 1 inch distal to the ligature, and the coverings of the cord are approximated with fine plain catgut. The cord is then allowed to fall back into the canal, and the external oblique is repaired by interrupted sutures of chromatized catgut until the external ring fits snugly around the cord. After careful hemostasis, the subcutaneous fat is approximated with plain catgut, and the skin is closed with interrupted sutures. Second operative line is herniorrhaphy in older patients and large or long-standing hernias. The inguinal canal should be repaired after complete excision of the sac. من أمثلة الهرنيورrhaphy Bassini operation or Bassini repair. It is a standard method. The lower border of the conjoined tendon is sutured to the inguinal ligament behind the spermatic cord by means of 4 or 5 equidistant sutures of non-absorbable sutures. If the sutures are tight under tension because the gap is wide, a tunnel release incision should be made into the anterior rectus sheath so that the sutures don't cut out. The drawback of the operation is that it abolishes the shutter mechanism of the inguinal canal by interfering with the action of the conjoined tendon. The red arrow indicates the line of tunnel release incision in the anterior rectus sheath. The second method for herniorrhaphy is Halsted operation. May be carried out as an alternative to Bassini's method in very large or recurrent hernias, especially in elderly and obese patients. In this method, the Bassini repair is reinforced by overlapping the aponeurosis of the external oblique behind the cord, which becomes subcutaneous. It is an excellent method, but since the cord runs directly through the muscles near the mid-inguinal point, the inguinal canal is no longer oblique and its valvular mechanism is lost. Another example for herniorrhaphy is blood goods operation. It's preferred by some surgeons because it preserves both the shutter and valvular mechanism. The posterior wall of the canal is strengthened by means of a triangular flap of anterior rectus sheath, which is turned downwards at its lateral border and sutured to the inguinal ligament behind the cord. The red triangle indicates the triangular flap turned in its lateral aspect to occlude the gap between the conjoined tendon and the inguinal ligament. Another method for herniorrhaphy is the Schultes repair. In Schultes repair, the idea is also to reinforce the posterior wall of the inguinal canal, starting with freeing a cuff of transversus transversalis fascia from the spermatic cord at the internal ring from the cremasteric muscle in such a way to make obvious the anatomy of the internal ring. Then the fascia transversalis, which is redundant of course, is splitted from the internal ring to the pubic crest. Then a double bursting sutures of fascia transversalis is done. This repair may be enforced by basin repair. The next method for herniorrhaphy is nylon darn repair. In this repair, we use nylon suture material as a two-layer darning in an attempt to obtain a tension-free lattice to reinforce the fascia transversalis and surrounding tissues. Lastly, the Liechtenstein tension-free repair. This repair has the capability of dealing with all types of groin hernias. This is an example of a direct hernia or a direct sac, which is freed well from the surroundings and is inverted back to the abdomen and sutured. A layer of sutures is taken over it in such a way to make the posterior wall flattened. In case of indirect sac, small one, also the sac can be inverted into the abdominal cavity, and a cone is inserted into the deep ring and sutured to the deep ring to keep the sac inside the abdominal cavity. In large hernia sac, it is excised. Then after flattening of the posterior wall and excision of the sac in large one indirect hernias, which is called the plug. A batch of prostheses with continuous sutures is embedded posterior to the cord with the continuous sutures to the inguinal ligament and to the conjoint tendon behind the cord, with two tails fitted snugly around the cord and fixed